joint,
You're gonna grab on.
pretty much the same way, right? But a good way to analyze it, which I don't want you to do for your test, but you can just put your hand like this,
Okay.
and that'll help you to determine how much A it is compared to the other side. This side's not coming up, right? And how much I is like this, right? Remember me telling you that?
Yep.
Just for clinical help on that. Also, you should have some pain out here in the front of it. You have trouble with the scapula. They can be fixated medially or laterally. How are you going to do that? How are you going to motion palpate it? Like, for instance, let's just say it's fixated in the medially rotated position, where the apex of the scapula has gone medial. How are you going to motion that?
It's gonna be stuck, you know.
What are you going to
Prone.
You're just going to have the patient adduct their arms, right? You're going to feel them glide up, right? Remember the ratio? It's 1 to 3 ratio. The scapula rotates as the humerus is abducted. Okay? If it's rotated and fixated in the lateral position, how are you going to motion that?
Adduction.
You have the patient prone. You're going to be on the lateral aspects here. And you're going to be moving them in this way. You're going to be rocking them yourself. Okay?
Wing scale. Got a wing scale.
You're not fixated.
So, let me have a patient, your patient. So, these are going to be done on skin. I want you to remember that. When you're motion palpating this, make sure you're in here on skin. I don't want you out here. You got to be in at the joint. So you have the patient shrug their shoulders, right, and put them down, and you can have them retract them and protract them, push them forward and pull them back, and you're going to feel the whole joint movement up and down and around and so on and so forth. Okay, so everybody got that? Most of the time, the problem is going to be it's gone anterior. Lots of ways to do this. The way I want you to do it on the test is make sure the patient puts their hair in a ponytail. After they do that, you're going to have them cup their opposite breast. That's it. On the side, breast is opposite on the side you're standing. You're going to come in, you're going to palpate right here, right over the proximal clavicle. Your elbows are going to be opposed as you're putting your force in here, and your thrust is going to go pretty much just A to P. Or you may have to torque it if it's got some superior movement. Okay? If it's gone posterior and you get that, the only thing you're going to do is palpate it, and you're going to bring this arm up like this, just like this, 90 degrees of abduction and elbow flexion, then we're going to extend, and you'll feel that. That's basically all it is. Okay? Everybody got that?
Mm-hmm.
If it's a AC joint, you can just stabilize this and you can push down here. Do it with your second metacarpal phalangeal joint. In order to adjust that, you can just simply bring this up like this and bring the arm here, and then you're going to, instead of extending, now you're going to externally rotate. And as you externally rotate, that brings the scapula and everything back, but I'm holding the clavicle here. Okay? If it's an AC joint, glenohumeral joint, and it's gone anterior and inferior, you're going to take the patient's arm like this, you're going to palpate onto the humeral head, take it back and around like this, you're going to hold it in position here, you're going to fully supinate like this, have the patient cup their breast, and let this arm relax a little bit. There you go. That's how you want it. Stabilize the scapula here. I have it all pulled into position. Come up here, up underneath here, and take your thrust this way. And you can add some external rotation with that too. Okay. The scapula, if it's fixated medially, that means you're going to have the patient abduct their arms as you're motion palpating the scapula rotating. You're going to have the patient, if they're having trouble with that, you're going to have them lay on their side, face you. And have them come scoot forward. Thank you. Put your arms like this, here. And I'm going to stabilize here up the glenohumeral joint. I'm going to come down here and contact the inferior angle of the scapula, medial inferior angle. I'm going to do that with my hypothenar, and I'm going to take this, take out my slack, and I'm going to thrust it back this way. Okay? If it has gone laterally, have them lay face down. And if it's fixated laterally, it's not gonna rotate immediately. So use your phenars, push these in like this, feel one side versus the next. After you examine that and you don't feel that it's gliding medially as it's supposed to, have the patient lay again on their side and face you. And what you're going to do is you're going to come up and now you're going to use your thenar for the contact. You're going to come here, again stabilizing here at the glenohumeral joint, and you're going to thrust this way. To restore it back. If you have a hard time doing that, you can take the patient's arm like this, you can lay it back like this. It helps to stick the scapula in on the inferior lateral angle of the scapula is where you're going to be doing contact. So all your contact points, when you're showing us on Charlie, you're going to show here, right? The anterior portion of the proximal clavicle, anterior or anterior superior. For the lateral one, you're going to be here on the superior aspect of the clavicle, lateral clavicle, or distal clavicle at the AC joint. For the glenohumeral joint, your contact is here. Everybody? Is what? You're going to be thrusting up through the elbow, the glenohumeral joint. If it's on the scapula, if it's gone lateral, you're going to contact the lateral inferior border here, right? If it's gone medial, it'll be on the medial inferior border. These are the contact points we're showing, right? If we're contacting and examining the elbow, and if you're going to be adjusting the ulna, we're going to be contacting right here. And that's either with a thenar, right? Heel of the hand, thenar area. Marble shooter's grip. You can use this. But you're going to shove that back P to A, right? If it's gone medial, you add a little bit of this to it. If it's gone lateral, you can add a little bit of this to it. And then the radial head, we just went over that, is right here. Hand down at the side, fully supinated, and thrust through. Okay? Through the elbows. So to motion palpate the ulna, what you're going to do is you're going to motion it like this. Hold this steady and move this back and forth. What are we feeling for?
Mushy and
Spongy and feel. So you do this and you say, okay, remember you always do a bilateral comparison on all these. You have to do that on the test, so make sure you check the good side first. Let's say that has a nice bony locking and this does not. In the adjustment, you're going to hold the hand like this. Remember, you're going to come up underneath it with the heel of your hand, take out your slack, and once you've taken out the slack, pump it a couple times and just thrust it this way. This way. Practice this, remember, it's not this. Okay, the other one, radial head, you're just going to motion palpate it just like this. Fully pronate and supinate, and you're going to feel for that radial head to be rotating there at the trochoid joint. And then what you're going to do is take it like this, fully supinated, put it at the patient's side, contact the lateral posterior aspect of that, and you're going to come in just like this. I'm coming in P to A and lateral to medial, and I'm going to thrust right through. Okay? Everybody got that? That's the moves. So practice them all. Anything you have trouble with, let me know. Who wants to test tomorrow and who wants to test? I mean, I can just take half the alphabet. It's fine.